Prior to beginning the activity, please be sure to review the faculty information and disclosure statements, as well as the learning objectives. After listening to the activity, complete the post-test by clicking the Earn Credit link in the episode description. Downloadable slides and resources are also available. The following presentation is copyrighted by Medscape. No use, broadcast, or recording of this presentation or any part thereof is permitted without the written authorization of Medscape.
The following presentation is part of a certified educational activity provided by Medscape Education and supported by an independent educational grant from Johnson & Johnson.
Hello and welcome to this Medscape Oncology program titled The Intensity Equation, Aligning Multiple Myeloma Combination Strategies with Current Evidence. My name is Luciano Costa. I'm a director of the Multiple Myeloma program at the O'Neill Comprehensive Cancer Center at the University of Alabama at Birmingham. And joining me today are two of my very distinguished colleagues. We have Dr. Asekender Alawati. He's a professor of medicine in the Division of Hematology and Oncology at the Mayo Clinic Comprehensive Cancer Center in Jacksonville, Florida. And we have Dr. Nisha Joseph, who is an associate professor in the Department of Hematology and Medical Oncology at the Winship Cancer Institute at Emory University in Atlanta, Georgia. Welcome, both of you. Today's program addresses a significant practice gap. Despite clear evidence suggesting that anti-CD38-based quadruplet and triplet therapy, there are segments of the community-based oncology that continue to rely on doublets and other suboptimal therapies in the treatment of patients with newly diagnosed myeloma. There are some potential barriers in practice that might include lack of familiarity with more intense multi-class regimens and physician concerns about tolerability, particularly in older, frail patients. Today, we will discuss how we can safely leverage these regimens to provide deep, durable responses and prolonged survival outcomes for nearly all of our patients. Let's start with a look at the clinical evidence in the first-line setting. I'll ask you, Nisha, to give us an overview of the data supporting intensive therapy that has set the new standard of care in those patients with newly diagnosed myeloma.
Absolutely. Thank you so much, Luciano, for the introduction. So first, we're going to start talking about some of the data from newly diagnosed transplant-eligible patients. So here you can see the schema from the randomized phase 3 Perseus trial, asking that exact question: is there a benefit of adding a monoclonal anti-CD38 antibody, in this case daratumumab, to an RVD backbone, so lenalidomide, bortezomib, and dexamethasone? So here you can see newly diagnosed transplant-eligible patients between the ages of 18 to 70 were randomized 1-to-1 to receive either RVD or dara-RVD for 4 cycles, followed by transplant, 2 additional consolidative cycles of the same regimen. And then patients on the DARA arm received DARA and LEN maintenance with the option of de-escalation at 2 years to LEN alone. And then patients on the RVD arm received LEN maintenance until progression. The primary endpoint of the study was PFS. And you can see here PFS data from the first data presentation with the median follow-up of 4 years. You see significant 4-year PFS benefit favoring the quad over the triplet, 84.3% versus 68%. And when you look here, unsurprisingly, we know the depth of response translates to a PFS benefit. We're seeing these rates of CR or better with dara-RVD, 87.9% versus 70.1%. You still see a very high stringent CR rate, almost 70% versus 44%. And if you look at the forest plot on your right here, we're seeing that benefit really across all subgroups. So again, really showing the ability of the regimen to obtain deep responses in all myeloma cohorts. And further, we look now at MRD negativity rates. Looking at sustained MRD negativity, you can see over a doubling of that MRD negativity rate, 65% versus 30%. And that's continued. We continue to see that benefit even sustained at 2 years. So 56% versus 22%. So again, deep responses translating to a PFS benefit, seeing sustained high rates of sustained MRD negativity even at 2 years. So similarly, this is a schema from the GMMG HD7 trial, similar design, but now using isatuximab instead of daratumumab as that monoclonal anti-CD38 addition to the RVD backbone. And then there's part 2 of the study, which we do not yet have data from, which I think is going to be really interesting to see, hopefully here in the near future, because what this trial did in contrast to Perseus is there's a second randomization here for maintenance. So patients, regardless of what induction they had, they're again randomized to either receive ESA with lenalidomide maintenance or lenalidomide maintenance alone. So really answering that question, do we really need a monoclonal anti-CD38 in both settings? Or if we get the response up front, is that sufficient? So more to come from this trial in terms of maintenance, but let's focus on what we learned from part one of the study. There's dual primary endpoints here, MRD negativity as well as PFS. So here you can see initial MRD negativity rates here, again, seeing higher depth of response across the board with the quad or the triplet, either MRD all comers or patients who achieved MRD negative CR and MRD negative VGPR or better. Higher rates in the quad versus the triplet. We're able to get a higher depth of response with the addition of that antibody. And that's translating to a benefit here in the PFS. There hazard ratio of 0.7. Overall, both trials really showing the benefit of that monoclonal antibody addition, the benefit of a quad over a triplet, particularly in transplant eligible newly diagnosed myeloma. And so I think some of the key takeaways from these three trials is that quads really have become standard of care, period, for newly diagnosed transplant eligible patients. That addition of that monoclonal anti-CD38 leads to increased depth of response that's translating to a PFS benefit across subgroups of myeloma patients. And what's really important here is that addition, we don't want to have an addition of a drug increase toxicity, and we're not seeing that. This is safe, this is effective, and patients are doing well with it. Any combination with a RVD or KRD backbone and a monoclonal anti-CD38 are some of the options that I would think about for newly diagnosed transplant eligible patients. And so with that, I'll transition over to Sikander to talk about transplant ineligible now, who are a very different population, often older, often frailer, multiple comorbidities, and how are we really approaching those patients and what is becoming standard of care?
Thanks a lot, Nisha. Thanks for setting us up so well with this initial portion about the transplant eligible. So I'll walk us through some of the data around transplant ineligible patients, which is also a very important component of the landscape of myeloma treatment, where the average age is somewhere about 70 years. And the patients can have their own comorbidities. So the first trial over here is the phase 3 Cepheus trial, which was for patients that were transplant deferred. I do want to clarify that ineligible could be that they just cannot receive it, or in today's day and age, the patients could be potentially deciding not to undergo the transplant. So how this study was set up was that the key eligibility criteria were transplant either ineligible or those who decided to defer. This was decided at the very beginning, newly diagnosed patients. So the patients had standard performance status and frailty score of 0 to 1. They were randomized 1:1 to either bortezomib, lenalidomide, or dexamethasone combination, VRD, or subcutaneous daratumumab with the bortezomib, lenalidomide, dexamethasone. So the DARA VRD, which is the quadruplet. And the patients received their initial therapy. After 9 cycles, the VRD arm went to just RD, and the DARA VRD arm went to DARA with RD. And the primary endpoint was overall the MRD negativity CR or better rate. The results of this study is showing that at a median follow-up of nearly 59 months, and the MRD negative CR or better at the 10 to the power minus 5 was significantly better with the quad arm, the DARA VRD, as against the VRD. You can see nearly 61% versus about 39%. But then when we look at a deeper threshold of MRD negativity CR or better at 10 to the power minus 6, even there, it was 46% for the quad versus 27% for the triplet. So adding daratumumab to the VRD significantly improved the depth of response. And you can see the progression-free survival, which is at the cutoff point, you can see 54 months PFS. There is 68.1% with the quad versus nearly about 49-50% with the triplet. So significant efficacy improvement with the quad. Now, the next trial I'll talk about is the phase 3 IMROZ trial, which was for transplant ineligible patients. And the way this was set up was, again, newly diagnosed patients, but allowed patients up to the age of 80 years, a large study, 445-ish patients. They were randomized 3:2 to either ethotuximab with bortezomib Blendex, so ETHA-VRD, or the triplet VRD. And this induction was 4 6-week cycles of the quad versus the triplet. After that, the bortezomib was actually dropped, which is something reasonable to keep in mind because we feel that this population may not tolerate the bortezomib, side effects, etc. It's important to keep in mind that the bortezomib was given at the 1 4 8 11, so twice a week for 2 weeks on, third week off. When we look at the progression-free survival in the intent to treat population, it was significantly better for the quad as against the triplet. So even giving that quad for the earlier few cycles to get that depth of response, and then potentially taking out the bortezomib part and continuing the rest of it, it showed significant improvement in progression-free survival. And this is also followed up now at 5 years. So good long follow-up for this data set as well. The third trial that I'm touching upon is the phase 3 benefit trial, which is for older transplant ineligible patients. Again, a decent number of patients, 270 patients, which were stratified by either age less than 75 or 75 and older. So this is, again, looking at a slightly different question. Both the arms are getting the CD38 monoclonal, and one of them is getting the bortezomib while the other one is not. And this is kind of building upon the monoclonal IMiD dex regimen where we feel whether or not bortezomib is adding anything. So the study is answering that question. The first 12 cycles were ESA-VRD or ESA-RD, and then beyond that, the dexamethasone was actually stopped. So another important question being asked in this population is dex really doing anything or not? So cycle 13 to 18 were ESA-VR or ESA-R, and then beyond that, this is important to keep in mind that cycle 19 onwards again, that is the bortezomib is also getting dropped. So both the arms become kind of similar. So the quad goes from ESA-VRD to ESA-VR to ESA-R. And so there is a way to how to de-escalate in these patients. And what this data showed was the MRD negativity, which has become the hallmark, very important point to look at the depth of response in these patients. Are the patients achieving that or not? And so what we see is that the MRD negativity at 18 months in an intent to treat population is significantly better in the patients who started with the ESA-VRD. So you can see on the left side is the 12-month data at 10 to the power minus 5 or 10 to the power minus 6. And to your right is the 18-month data, 10 to the power minus 5 or 10 to the power minus 6. In all those setups, the patients who started with a quad, even though they had planned de-escalation, are having a significantly better depth of response. So the way I look at it is that these data are demonstrating to us that majority of our patients, whether they are transplant eligible, ineligible, deferred, they do really benefit with that initial intensity of the treatment up front with the greatest chance of achieving a depth of response, even though that may have inbuilt de-escalation at some point, but you're almost setting the patient on the right trajectory as the patients start the treatment with the right approach.
Yes, thank you so much, Sikandar, for a great exposition. So, given the weight of the evidence for intensive therapy, what about our high risk or frail patients? So, to answer that question, let's take a look at the data on those specific patient population. So, just want to go back, now several years, there was this prevailing idea that CD38 monoclonal antibodies were beneficial for patients with, standard risk myeloma, and perhaps not so active in patients with high risk disease. That initial perception was based essentially on the small number of patients that with high-risk disease that were accrued to clinical trials. So when you gain the power of meta-analysis by pulling all this data together, becomes clear that the benefit of CD38, even though of a lesser magnitude, it is still present and is very significant, even among patients with high-risk disease. Now, of course, the question becomes, what other drugs still belong? I think Sikander made a very good point, demonstrating the benefit of proteasome inhibitors. And I think one drug that is often overlooked is actually corticosteroids. So the REST trial, which is intended to replace steroid in transplant ineligible patients with multiple patients who are not eligible for transplant. So clearly some older and some more frail patients here. And the trial builds into this proteasome inhibitor immunomodulatory agent, specifically monoclonal antibody corticosteroid, but has, just like Sikander was mentioned, you have the early intensity to debulk disease, prevent in organ damage, rapidly improving the disease burden on the patient, and then it slowly kind of pulls back, omitting corticosteroid already after second cycle, omitting a proteasome inhibitor after the eighth cycle, and then just continue this E38 monoclonal antibody beyond 18th cycle, continuing only with the immunomodulatory agent, in this case, lenalidomide. And the sample size is relatively small, but look, a population with a median age of 77 years, 31% above the age of 80, 45% considered frail. And here we are doing quadruple therapy, which is until not so long ago was almost synonymous with transplant eligibility. And what they found was a very universal rate of response, 100%, including more than a third of the patients achieving MRD negativity, and 12-month progression-free survival, 86%. And importantly, less than 10% of the patients are discontinuing treatment due to the adverse event. And when you look at the breakdown of common side effects, that looks like what you would expect even a younger patient population. Cytopenias, particularly neutropenia, being the most common, but we all are now very comfortable dealing with those toxicities, and they are uncommonly associated with infection. Now, so we got to think about moving beyond this arbitrary age as a cutoff to decide treatments for patients. We like to invoke the 2026 ASCO Living Guideline and that emphasize the chronological age alone is not a contraindication for intensive frontline myeloma therapy. And I think that those of us who have been involved with transplant have been exercised that judgment for many years now, not subscribing to a harsh age cutoff, but rather taking consideration other features, including patient comorbidity, performance status, and in a way, tolerance to risk. I think that same mindset now applies to choosing different combinations, including extending the benefit of quadruple therapy for some older and more frail patients. So utilizing validated frailty assessment helps expand the access to optimal therapy and avoid the risk of frontline under treatment, which I think is probably higher than a risk of overtreatment. So we're now seeing how we can dose optimize the partner drugs to mitigate the risk, something that we all do in clinical practice. For example, using less dexamethasone, using weekly bortezomib. Nisha and Sikander, how are you adapting these regimens in your practice in the face of frailty or significant comorbidities?
Yeah, absolutely. I think exactly as you outlined there when talking about the REST trial, I think it's really important to treat the patient. We want to use quads, but I often will use weekly bortezomib, as was just talked about. I certainly dose reduce the dexamethasone. I'm very cognizant of trying to taper that down quickly. I think we're learning more and more that I think there is some benefit up front, but that benefit tapers off quickly, and it just leads to added toxicity, particularly in older and frailer patient population. And then I think also standardly, don't forget about the lenalidomide as well, starting at a lower dose. You don't need to push at 25 for some of those older patients. Finding that balance, you're more likely to be able to keep patients on multiple cycles of induction, get that benefit without that toxicity, and then able to transition to the maintenance regimen. And that's how I tend to approach it in the clinic setting.
Sikander, any other tips? How you
No,
doing
I
with?
think that's Nisha summarized it very well, and I absolutely agree. What we have to always keep in mind is the mindset is to get to a deep response to try to mitigate all the morbidity from the myeloma and prevent any myeloma related body damage. And the moment we reach there, especially in this older, frailer population with other comorbidities, these studies are showing us that we don't have to stay on all those drugs forever and ever, but it is extremely important to get to the desired point. We must start with the right regimen. Once we start with it, we can scale back, and hopefully that response stays, that long-term benefit will end up staying. But we need to not think, let's start slow and then we'll build up gradually. And to Nisha's point, I think dose adjustments and schedule adjustment becomes very important also, whether it's weekly bortezomib, adjusting the lenalidomide, adjusting dex dose, etc.
I couldn't agree more, Sikander. So we know that achieving deep and durable response early disease course is correlated with long-term survival. Now we start talking about cure, and I think an easier concept to embrace is the concept of functional cure, meaning that disease is controlled so deeply and durably that it causes no symptoms and allows a normal lifespan. This is especially crucial to transplant ineligible patients. We always have this mindset that the therapy for those patients is somewhat compromised, but I think we're living in an era now where that no longer has to be the case. So let's talk about some real world scenario. Let's talk about let's pick a typical case. Let's think of a 74-year-old man with newly diagnosed and cytogenetically standard risk myeloma. This patient has some hypertension, some mild chronic kidney disease. Come to you with a recall performance status of 1. He's independent of the activities of daily living and resides at home with his spouse. So his oncologist referred him to a transplant center to assess transplant eligibility and is consider options for induction treatment. So what do we need to consider here, right? So he's a 74-year-old, but is active and relatively fit, and has some cardiovascular and some renal risk features. So maybe we start, with you, Sikander. I mean, what goes through your mind when you sit in front of a patient with those characteristics? What you discuss and present to the patient as options and considerations?
Yes, excellent case to discuss because this is very representative of what we see in our clinics day in and day out for newly diagnosed myeloma patients. So generally in this situation, Luciano, our thought would be how can we optimize the treatment for the patient? So it's very important to understand that as you rightly and very nicely laid out was the patient's chronological age, but also what may be their functional status. It's important to figure out how far is the patient from the treating center? Do they have caregiver support? Do they have other symptoms that need to be addressed like pain and other supportive care? So, with all of that in mind, I think this would be a perfect example of where the patient, in my opinion, must start on a quadruplet. But for example, they do not need to get bortezomib 1, 4, 8, 11. They can easily get it once a week, 1, 8, 15, 22. That simplifies the schedule, brings it in line with that SCD38 monoclonal. The dexamethasone can be given only on the days of the monoclonal, even preferably as a pre-medication situation, so that the same dex can take care of both the needs of pre-med and the anti-myeloma therapy. And then that's how I think Nisha had laid out also very well about does the patient really need to start on lenalidomide at full dose? Well, with chronic kidney disease, there is need to adjust the treatment so the patients don't run into side effects like cytopenias, etc.
But I'll hand over to you, Nisha. I don't know what if you want to add more things to that. Please go ahead.
Yeah, thank you so much. I mean, I think the other question, certainly a quad for this patient. I think the other question is still transplant versus non-transplant. I think he's certainly more borderline. And I think now compared to 5 years ago, before Safius and Imraz, this might have been more straightforward than it is now. I think, I think it depends a little bit on the degree of the CKD and hypertension, his support, et cetera. I still think I would consider transplant potentially in someone like this, but regardless, this would be someone receiving a quad. Maybe the quad is maybe the litmus test to see how fit that person really is. Depending on how he does with quad, then maybe have a conversation. But I think he's fortunate that he has multiple options there that he could benefit from these things.
No, I think that is, I couldn't agree more. I think there's a very strong sentiment in our field that we have to divide people right away between transplant eligible and transplant ineligible. And I think that goes back to the old days when, patients who transplant eligible get melphalan prednisone and forever ruin their chance of getting transplant. And patients who are transplant eligible will get VAD and then proceed with transplant. And I think in a kind of a very interesting, funny way, our field has gone in all directions and converge in a way, right? So I think in a way has taking, we still artificially divide the patients. I think that's going away. And I think the fact that we have quads for both really put an emphasis that we don't need to make the call right away. Sometimes our impression is shaped by the patient's frailty and symptom burden, and that of course is very modifiable, particularly in what relates to the disease burden as opposed to comorbidities or other medical ailments. So another barrier to optimal intensive first line therapy is the idea that if we use everything up front, there won't be much left when the relapse occur. I call this the empty shelf anxiety, which I think this still drives sometimes or many people decisions. For example, let's consider our patient again. Let's say he receives the atumelumab and VRD, achieves good disease control, becomes eligible for transplant, and stays here for 4 years and then relapse. Where do we go from here? So maybe Nisha, you might be a good one to start us off with some of the latest data on treatment options for patients with first relapse.
Absolutely. So let's talk a little bit before we get into data, some of the things that we think about. And so we've been very fortunate, particularly here in recent years, that in the relapse setting, we have a lot of choice. We have a lot of the standard myeloma therapies and triplet combination, and now we're starting to get access to some of the novel immunotherapies that we'll talk about here in a second. And so when we're trying to decide what really is best for the patient, what are some of the factors that we think about? So certainly refractoriness is critical to think about when we think about next line. And we're really moving away from number of prior lines of therapy. And even when we design trials and really thinking about more about what has that patient and then that myeloma seen to date? What are they resistant or refractory to? What about how the disease is behaving? What kind of relapse are we talking about? This is a rapid explosion of disease. Is this a more indolent progression? Is the patient presenting with high tumor burden? Are they presenting with extramedullary disease, which historically is more difficult to treat and can be more aggressive? Does this patient have cytogenetic high risks? Or are they functionally high risk, not behaving despite the lack of cytogenetic high risk features? Are they behaving high risk and not responding the way we would expect them to standard therapies? And then things we've referenced as are always really important patient-derived factors: the frailty, comorbidities, logistics, how far do they live? Do they have a caregiver? And of course, most importantly, their own preferences and what their own goals are for themselves. So with that in mind, let's take a look at some of the clinical trial evidence that we have to date. So here is the schema for the CARTITUDE-4 trial. This was a randomized phase 3 trial looking at the role of cilta-cel, of BCMA CAR T-cell therapy in early relapse. So patients with 1 to 3 prior lines of therapy, including a PI and an IMiD, had to be Len refractory, good performance status. They were randomized 1-to-1 to either standard of care or cilta-cel. The standard of care arms were options between pomalidomide, bortezomib index, and darapomalidomide index, and that was PI discretion. primary endpoint of the study was PFS. You can see here patient characteristics, and we're really focusing in and honing in on first relapse with one prior line of therapy. And on the right, focusing again on one prior line of therapy, but specifically functionally high risk patients. So, again, folks who are not responding appropriately or the way we would expect them to frontline therapy. About 50 to 60% of patients have high risk disease. You see about a quarter of patients have ultra high risk disease, so meaning two or more high risk cytogenetic abnormalities, and around 15% of patients had soft tissue plasmacytomas. And then you can see here the PFS. So on the left, we're looking at one prior line of therapy. On the right, one prior line of therapy and functionally high risk. And you can see here a significant benefit in PFS with cilta-cel. So the 1 year PFS, 78% versus 59%. And then in that functionally high risk category, even more pronounced difference here, which is 77% versus 49%. And then you can see overall survival here with the median follow-up of around 34 months, the 30-month OS, again, favoring CAR T-cell therapy, 76% versus 63% with a hazard ratio of 0.55. So again, all in all, showing a benefit of CAR T-cell therapy. And this data is showing us that this is a good option potentially for patients with functionally high risk or high risk disease at early relapse. The caveat or complicating factor here is the standard of care options in this trial are different than what we currently have available to us now very recently in the clinic. And so I'll turn it back over to Luciano to talk through some of that clinical trial data and how we're incorporating that into clinical practice.
Thanks, Nisha. Recently, we had the chance to see the data for what was the first randomized phase 3 trial with bispecific T-cell engagers in multiple myeloma. And I think, Nisha, like you mentioned, patient population is very important. So these were exclusively patients with CD38 naive or CD38 exposed but sensitive disease. Disease never progressed shortly after CD38 monoclonal antibody. And of course, the choice for those patients in our clinic until very recently was a CD38 monoclonal antibody in combination with pomalidomide or in combination with bortezomib or in combination with carfilzomib. So this trial, Majestic 3, randomized patients to receive one of those standard regimens, DPD or DVD, or to receive a novel regimen with the daratumumab in combination with the teclistamab, which is the BCMA-directed T-cell engager. The other thing that I think was interesting here on this trial is the initial approval, initial use of teclistamab in patients with much more advanced disease was based on a weekly schedule. And here what we did is we adapted the schedule of teclistamab to match the schedule of daratumumab that we all very familiar with, which is weekly for 8 weeks, then every other week for 16 weeks, and then every 4 weeks thereafter. And the primary endpoint of this trial was progression-free survival with several secondary efficacy and safety endpoints. Here we have the study population. Everybody had to be exposed to lenalidomide, so 100% in both arms. Everybody had to be exposed to proteasome inhibitor. And you have about 5% of patients in each arm exposed to CD38 monoclonal antibody. But of course, none of those patients had CD38 refractory disease. And we saw a very strong signal of improving efficacy on TEC-DARA over DPD or DVD. The rate of response was 90% versus 75%. Perhaps more impressively, complete response were 82% versus 32% with DPD-DVD. And when you look at the progression-free survival, the control arm performed even better than we would expect with DPD or DVD based on the Apollo or the Castor trial. And here the median was 18 months. But with the experimental arm with TEC-DARA, we did not reach a median, and we have a 36-month progression-free survival of 84%, giving a hazard ratio of 0.17, which I believe is still the lowest we have seen on any randomized trials in multiple myeloma. Very recently, my colleague Raul Banerjee from Fred Hutch presented at EHA the subgroup analysis in terms of risk status. And we all have now embraced the knowledge that the cytogenetic abnormalities, high risk cytogenetic abnormalities, have a cumulative effect in affecting prognosis. And those patients with two or more high risk chromosome abnormalities, that we often call ultra high risk disease, are especially hard to treat. Those patients progress very quickly despite quadruple therapy, and have a hard time responding to subsequent therapy. So what we see here is the same high magnitude of improvement is seen across all risk strata. And for those patients with two plus high risk chromosome abnormality, now you have a 76% of 3 years progression free survival, which is really a zone parallel with about any other therapy. Another population that is gaining more and more interest because it's of being so challenged are the patients with functional high risk disease. Here are patients who received one prior line of therapy, but were progressing within 18 months of that initial therapy. And again, you see that at 36 months, none of those patients on the control arm are alive and progression free, versus 77% of the patients who receive Tecdara. Now, a new therapy comes with new toxicity profile. I think there was a lot of expectation that this combination could be exceedingly toxic, particularly in the terms of infections. And what we saw that is overall, the rate of adverse events grade 3 and 4 were comparable between the two arms. The rate of high-grade neutropenia was comparable between the two arms. Cytokine release syndrome, which is a signature toxicity of T-cell redirecting therapy, was seen in in about two-thirds of the patients with Tecdara, but not a single patient had a grade 3 or higher, and consequently, not a single patient died from that toxicity. The main signal here is evidently the high grade infections. This I think is one of the most important teachings of this trial. Yes, for sure, Tecdara caused more infections. Some of that was mitigated with an aggressive plan to do prophylaxis with acyclovir, PJP prophylaxis, and IVIG. But interesting enough, that imbalance in infections, in high-grade infections, really happened in the first 6 months. And beyond 6 months, the risk of infection is not any higher than would expect on this population getting any other daratumumab-based regimen, as exemplified here with the control arm getting DPD or DVD. And I think we see this same pattern happen over and over again in different settings with different regimens, that the disease itself is often a big driver of infection. And once you have gain of control over the disease, the risk of infection goes down. So, in addition to these immunotherapies that have recently been approved in the second line, Sikander, perhaps what trials are expecting more data in the upcoming years? What is exciting you the most?
Thanks a lot, Luciano, for walking through that information and data. So I think as you both have mentioned very nicely, that the field is moving extremely rapidly. So I'll just touch upon some of the studies that I think are going to be interesting and will help shape our myeloma treatment over the next few years even further. So one of them is this linker MM2, which is a phase 1b investigation for linvoseltamab, which is another anti-BCMA bispecific antibody in combination with anti-CD38 monoclonal after 2 to 3 prior lines of therapy. So a combination is linvo with either DARA or linvo with ISA as the two cohorts. And the prior DARA or ISA treatment was permitted if previously the patient tolerated it for 6 months or more, or and they have to have a specific washout. This is also very important because remember, we have talked about Majestic 3 and we have said that that was mostly data naive, but we need to figure out what are these bispecifics bringing to the table when combined with the CD38 monoclonals if the patient has previously been treated with the CD38 monoclonal, which is typically the population that we end up seeing. So the study had clear washout periods. And at a median follow-up of nearly a year, the treatment with Linvo and Dara or Linvo and ESA combinations is showing high rate of durable responses. The overall response rate is about 87%, with CR or better, a very healthy 53%. And the 12-month duration of response is 77%. So patients respond fast and they tend to stay in that response, with the 12-month PFS being 74%. Now, this is very early, and as we said, this maturing data is further awaited. Another trial shaping how we treat myeloma is the redirect one, which is teclistamab plus talquetamab after triple class exposure. So the rationale is to use a dual targeting approach, not only against the BCMA with teclistamab, but also against GPRC5D with talquetamab, so that antigen escape and clonal resistance may hopefully be avoided. The schema lays out very nicely how the study was set up so that the patients could transition from Q weekly to Q2 weekly, and then from Q2 weekly to Q4 weekly after achieving a PR or better after cycle 4. So now we are looking at a response adapted de escalation early on rather than that the patient starts and stays on that regimen. And what the redirect one is showing us is that when we look at patients with this combination, on the left side, top left, is bars showing all the patients, how they are responding. But I would like us to focus on that extramedullary disease cohort, because that is one thing where we have seen that the bispecifics may not be that beneficial, especially BCMA-directed bispecifics. So bringing in this combination, we saw encouraging results with deep responses, early deep responses. And even at the median follow-up of 18 months, these deep responses with notable ones in extramedullary disease are very encouraging. The 18-month overall progression-free survival rate is nearly 70%, and the follow-up is still going on. So I think as a patient's um, treatment progresses in myeloma, there are some strategic shifts that are happening with all of these highly targeted therapies. So the patient's drug refractory status informs us that the risk benefit of subsequent therapy at relapse becomes extremely important discussion point. This is again where the informed decision making comes. This treatment selection must prioritize the therapies that have the greatest survival benefit and that reduce the risk of attrition with subsequent lines of therapy. We've seen that with all these regimens lining up, that these T-cell directed therapies are being used early on. That's when they're giving the best benefit to our patients. I think the question that many of our colleagues ask is, how does a first-line anti-CD38 exposure impact our ability to use it again in a later line? So I think that is where this prior anti-CD38 exposure and resistance importance is there in how we define the management for the patients. We do know that the evaluation of daratumumab re-challenge after 6 to 12-month washout period can be successful use. And we were able to see that in, for example, the linker MN2 data, that as long as you had the washout, you could get benefit with that again. So among patients that have had prior DARA exposure in Majestic 3 and DARA refractory patients in the TRIM2 study, which was the talquetamab DARA, they showed significant clinical responses to the bispecific and DARA combination, which makes this a valuable option. So retreatment becomes an important option. And what fraction of this efficacy can be attributed to daratumumab's anti-myeloma activity versus its effect on regulatory T cells, that is yet to be shown, and that is still being studied as the data matures.
Thanks, Sikander. This absolutely. As we near the end of today's program, let's talk about some actionable strategies our colleagues can implement to improve access to standard of care therapies for their patients.
I think one of the take-home messages is let's optimize early treatment intensity to maximize survival outcomes. Quadruple therapy is the current standard of care for most patients we see in the first-line settings. Trial regimens can and should be adapted and tailored to each individual patient. And I think the things that we heard about today is consider weekly bortezomib, which is uncommonly used in clinical trials, but is very much the mainstream in clinical practice. Consider decreasing the dose of lenalidomide at least at the beginning. I use dexamethasone very wisely, perhaps with a reduced dose, reduced frequency, and be comfortable just continue that early on once your patient gains some good response, and many other strategies that we discussed today. In terms of novel immunotherapies, coordinating the step-up dose and CRS monitor requires some communication between academic center and community sites, at least for the near future. I think more and more we're going to have widespread familiarity with those agents and widespread comfort that I really believe that any practice that is treating myeloma patients anywhere in this country should be able to administer T-cell engagers safely. Early in the size of toxicity management is essential to optimize outcomes, which is directly agents. And there's the value of community academic referral and consulting network cannot be overstated. Of course, we in academic have the privilege of getting first exposure to those newer therapies, sometimes be involved with the trials that help shape the future of myeloma. But our patients rely mostly on the community oncologists, as the vast majority of patients with myeloma are treated in the community. I'd like to go back to you, Nisha, to give her some final thoughts.
Yes, absolutely. I echo everything you said, and I think maybe the only other thing to say would be I encourage early referrals. I think there's never a scenario where it's not appropriate to refer a myeloma patient newly diagnosed. Certainly, we'd love to see them early and help weigh in across the journey. But really, at any time point, things in myeloma, I think, as you've seen today, are moving so rapidly and changing so rapidly. We're learning in real time how to best sequence and combine therapies. And so I think early referral to an academic center is really helpful to help guide treatment decisions for all of our patients.
Sikander, you got the last word.
Sure. Thanks a lot, Luciano and Nisha. This has been an excellent data review for everybody. But I think just adding on to what Nisha is saying, the time is extremely exciting for myeloma treating physicians and for myeloma patients. But at the same time, it can seem quite complex. So even if the patient is not referred right away, the important thing is just to keep this communication that Luciano, so nicely pointed out, that anybody and everybody from the academic centers would be available to just review, help understand the patient's specific individual situation and what may be most beneficial for them. There are quite a few options, but we can always help take those decisions.
Great. Thanks, Sikander and Nisha, for joining me today. And thanks for our colleagues in the audience.